Hello, and thank you for watching my presentation, which I delivered to my team yesterday, which was a CPD presentation on mental illness and pain. Now, here I cover our evidence-based approaches to helping our patients who are in pain, who have mental illness, or those whose biopsychosocial picture is more biased towards the psychological. Now, I'm sure that a lot of you guys have noticed because our patients have been less able to physically stress themselves because of lockdown, their presentations are by default becoming more psychosocial. I will discuss tools on how to deal with this. Now, I'm also just going to introduce the first couple of slides because I only figured out how to record in Zoom 5-10 minutes into the presentation. So first thing is, if I use any neuroanatomical terms, it's purely for metaphorical reasons. We don't know very much about the brain at all. What we do know about the brain, I will cover, but I'm using neuroanatomical terms or conceptual terms to bridge the gap between our understanding, so we have something concrete to base our understanding of. Also, during the first slide, I'm talking about psychological concepts, which we can once again use as in a metaphorical sense to understand the workings of our minds. The first which I cover is the psychodynamic approach, which was popularized by Sigmund Freud and later Carl Jung. Now, in the psychodynamic approach, we have the makeup of the mind, which is a triad, the id, the ego, and the superego. Now, we can use the ego to understand our self, our true self. But then as well as that, we have the id, which also is home to our inner child, which is our emotional selves. The emotional self defends the function or defends the health of the ego. And as well as that, we've got the superego, which is the internalization of, say, societal pressures or the pressures of, for example, our parents, and they in that lies social norms. So a common presentation for pain, for example, would be I'm, i.e. the ego, in pain. I feel very upset and very distressed and frustrated. That's the id about this pain. And then the superego might put pressures on the self to get back to work, to provide for the family. This causes the id conflict, greater internal conflict, and therefore that person has to try and resolve this internal conflict, which is when they come to see us. And this will have different presentations and different levels of intensity in association with different forms of mental illness. So I hope that you find the tools and the concepts that I covered just as effective as I have for my patient presentations and for my patient successes. And if you have any questions which need answered, then all you need to do is contact me at any point. I'll be more than happy to discuss any of the following. Thank you so much. Record onto this computer. All right. Yeah, so if you guys have any questions at all, just let me know anytime. CBT is the best evidenced form of psychological intervention that we have, and that is because it's very clinical. It enables an input variable and then to detect the outcome. This focuses on interaction between the environment and the self. This is very, very important for us who deal with patients who are in pain, because pain is very much a mechanism based on perception. How that individual perceives what's going on will heavily affect their pain, or significantly affect their pain. CBT is basically changing that person's perception to the outside world. So many of us who exercise will already have this, because we might have certain discomfort that we experience after exercise, but the context of that discomfort is very different to pain after an injury. Now, that's us who exercise on a regular basis. Many of our patients don't know the difference. So which is where we'll see, for example, untrained individuals, people who've never exercised before, and they can't quite tell the difference between a stretch, a pull, a strain, or pain. We've then got Eastern psychology, which has a huge toolkit for us to use. This focuses on consciousness, i.e. the observer. So here the observer replaces the ego in the psychodynamic approach. And we have the mind, which replaces the id. This is where we have emotions and processes. And then we've got the environment outside of this. All of these concepts are continuums on the same spectrum. They allow us concepts and metaphors to understand the mind. Any questions so far? All good? All right. So psychological concepts in neuroanatomy. So once again, this is a metaphor that we can all use because we've all studied anatomy. The psychological concepts can be summarized as an interaction between the self, which cannot currently be traced to a neuroanatomical structure, and the interaction between the self, the prefrontal cortex, and other areas. What I mean by this is that, so a philosophical question would be, if I was a brain surgeon and I could open up your brain and take bits away bit by bit, how much of your brain would I have to remove before I hold you? The reason why this is a philosophical question is we've got the debate between the materialists and the non-materialists. At the moment, the debate is out or it is open because there's no concrete answer. But we can say that the self, i.e. what makes you Ellie or David or Charmaine or Jess, is very different to your brain. So we can say that the self is separate, and then we have the different anatomical areas which influence or feed back to the self. One very important area when it comes to pain is the amygdala. The amygdala is otherwise known as the reptilian brain. This is where a lot of our primitive responses are. This is where our emotions, for example, are present, and the amygdala can have significantly different functions depending on which type of mental illness someone might have. Now, we can view pain as a top-down or a bottom-up approach with specific control centers along the way, i.e. we have the prefrontal cortex at the top. That's where logic and knowledge is. We've then got, say, this sensory somatocortex, which is where our sensations are. And then we also have our amygdala, which is where our emotions are. And we've got the body underneath. And these feed back between each other to gain an accurate perception of the world around us. So we can use, for example, the concept of central sensitization to understand how these different areas interact. So we've got a nociceptive input, which is just, say, a breaking or a breaking of tissue or a pressure applied to tissue. This isn't required for pain, but we'll add this in anyway. We've then got the WDRs, which are the wide dynamic range neurons. These are essentially amps. So these are amps to decide whether or not to amplify or to reduce the amount of sensation from the body. So these this is neurological tissue in the dorsal horn of the spinal cord. And we see that, for example, in chronic pain, these areas upregulate pain. They allow more stimulation to the spinal cord. This information is then picked up by the somatosensory cortex. This is where we have the interpretation as pain. The individual say, I feel pain. The amygdala here, once again, the emotional centers of the brain will say, I am worried. I will upregulate this pain to warn Sarah. The prefrontal cortex will say, I want to find out what's going on. I'll Google it. Wow, that's really bad. So this is how the prefrontal cortex is doing a disservice to the individual, is up-regulating the pain that they're experiencing by having catastrophic belief systems put in place. The amygdala will then feed back again and say, well, now I'm really worried. I'll up-regulate again so Sarah pays attention. The somatosensory cortex then interprets this and says, I feel more pain. Now, obviously, pain, as we know, pain is a partly learned response. So we can say that the more that this cycle continues, the more likely it is to occur. Nerves that fire together, wire together. However, we as pain clinicians can intervene and break this pattern in multiple ways. So as I said, if this process continues as it often does, the wide dynamic range neurons will upregulate pain, and the homuncular representation of the pain will become more blurred, vague, and fuzzy. That's why we get a lot of patients who come in who, after a while, their pain will go from being focal, specific, to very vague and blurred. Now, this is just to recap on pain mechanisms. We'll go into more specifically into mental illness. So, mental illness and pain. Depression, often seen with depression. Let's talk about depression for a second. So, depression is believed on the basis of more recent research to be a defensive mechanism of essentially shutting that person off from the world. So, the world is too painful. Let's downregulate any form of sensation from that world. The issue with this is that we experience less motivation. We experience a fairly dull outlook on the world. It's far more difficult to do basic things. The individual will be depressed, not just psychologically, but physically as well. So they'll feel it difficult to get out of bed. They'll find that often a common description is walking through molasses or walking through custard. So when they try to move, they can't because the whole system is depressed. This is partly a reduced sensitivity to dopamine. So when you hear me using these reductionists, when you hear me talking about mental illness, talking about key anatomy and key hormones, I'm talking about it in a reductionist way. This is just to stick to certain things which we can move on from. So it's just I'm just using them for stepping stones. Mental illness is very, very specific to the individual. So we can see here, and it's once again not as understood as we would like. So with depression, we have a reduced sensitivity to dopamine, a reduced capacity to down-regulate pain. So our natural painkillers are hindered. It is the leading cause of chronic pain, and we have a reduced secretion of dopamine and reduced sensitivity to dopamine. We also often see with patients who have chronic pain or patients who are chronically depressed, we see a more active amygdala. The amygdala, the area of the brain that produces emotions, is more active. With anxiety, this can lead the patient to overthink and catastrophize pain. Once again, this is a defense mechanism. This is a way for the individual to be hypersensitive to what is going on and what could potentially go on. It's almost like a fear of the future. With this, we can think that the prefrontal cortex is communicating with the somatosensory cortex and the amygdala in a catastrophic way. So, David, I know that you've got a patient at the moment who would ring quite true to this. A patient of yours who at the moment is asking a lot of questions, but also Googling a lot outside of the session. Their prefrontal cortex is acting in a catastrophic manner to upregulate their pain.
Describing that patient exactly of what you're going through.
Yeah. Okay. Perfect.
Yeah.
Perfect. We've got and I won't use patient names here just because I will share this online as well. So if we make sure that we keep any patient information out of the equation. So we also have borderline personality disorders and post-traumatic stress syndrome. So borderline personality disorder and other personality disorders are heavily correlated to child abuse. Child abuse, as we will see with these findings, with some research, with the findings from the research which I've quoted, cause an hyperactivity or an overactivity of the amygdala. The amygdala is hypersensitive again. Those diagnosed with BPD, so borderline personality disorder, also are often shown to have an increased activity of the amygdala. Post-traumatic stress syndrome, we can expect similarities there. Post-traumatic stress syndrome is a stress response which hasn't ended at the time of the stress, which can once again cause quite catastrophic symptoms for the patient. Another angle to look at with PTSD is, yes, what causes the PTSD or where the PTSD is anchored might be on what has happened to the patient, but it also might be on what the patient's done. So this is very common with ex-military, where, yes, absolutely, they might have PTSD because of what has happened to them, but also because they can't handle what they've also done. The guilt will cause them PTSD in that same sense. Chronic pain, an abnormal reaction to normal stimulation, as covered, also shown to have an overactivity of the amygdala. Early child abuse and poverty, they both cause an increased activity in the amygdala, and they can both reduce prefrontal cortex activation. This means that those who have gone through extreme poverty whilst growing up, or significant child abuse, will have almost be, I suppose, we can call it not stuck in a fight state, but their emotions have been upregulated to protect them. The prefrontal cortex has been less stimulated. This might mean that those who have gone through these experiences find it more difficult to understand their pain, more difficult to rationalize their pain, more difficult to down-regulate their pain. In it's a bit outdated now, but in I think it's the Matheson book, was it Orthopedic physical examination. They also correlate IQ to IQ is negatively correlated with chronic pain. So those individuals who have lower IQs are more likely to experience chronic pain. Now, it's easy to be too reductionist with this. This could just be that those with lower IQ are more likely to find themselves in lower paid work. Financial stresses is a yellow flag, which can also cause an upregulation of pain. Now, the ideal management of pain is when the spinal cord allows abnormal stimulation to, no, this is the ideal, that's it, yeah. The ideal management of pain is when the spinal cord allows abnormal or threatening stimulation, i.e. nociception, to ascend the spinal cord, not normal stimulation. We have a lot of patients where normal stimulation is allowed to cause a nosis or cause a pain response. So, for example, patients who have picked up something 100 times, and that one time it caused them pain, and they haven't been able to pick it up since. No inflammation, no tissue damage, just sensitization. In an ideal management of pain, the somatosensory cortex can create an accurate and functional interpretation of sensory input. No fuzz, no over-exaggeration, focal, refined, it does what it needs to do. The frontal cortex should be able to rationalize the sensations of the amygdala to down-regulate output. So what we're going to do when it comes to management is I'm going to split the following parts of this presentation into the following. We're going to look at mental illness specific presentations, how common mental illnesses may present themselves, how we can get in and out of the way of our patient's recovery. This is the most important part for us. There are multiple ways where we can elongate a patient's recovery. We can use language and interventions which just are not appropriate for a patient who is psychologically upregulating their pain. This is how we as therapists can compromise our patient's recovery and how we can facilitate their recovery the right way. We're also going to look at psychological intervention that we can use, tools that we can use to improve patient outcomes, ranging from CBT to mindfulness, etc. We're going to be discussing lifestyle with our patients, how changes in exercise, diet, and lifestyle can stabilize our patient's recovery. Any questions so far? All good? Sweet, all right. So let's look at depression. So once again, depression, we call it a defensive mechanism to down-regulate the experience of the environment to the individual. Psychological symptoms will be anything from continuous low moods or sadness. It can also be intermittent. Feeling hopeless or helpless. And just think about how this might manifest itself in conversation with the patient. The patient feels like they're giving up, feels like you're their last hope. They're trying to position you as the hero in their story. Having low self-esteem, feeling tearful a lot, feeling guilt-ridden, irritable, intolerant of others, having no emotional interest, difficult to make decisions, so indecisive. We might have to structure their recovery more, not getting any enjoyment out of life, feeling anxious or worried. Anxiety and depression do overlap. Having suicidal thoughts, harming yourself, or even hating yourself. Physical symptoms, moving or speaking more slowly than normal, as I discussed. Changes in appetite or weight, usually decrease but sometimes increase. Constipation, once again, that brings into the physical down-regulation of activity that's in depression. Unexplained aches or pains, lack of energy, low sex drive, changes to your menstrual cycle, disturbed sleep. We have general anxiety disorder, restlessness, sense of dread, feeling constantly on edge, difficulty concentrating, irritability. Physical symptoms can be dizziness, tiredness. These are things that we will often see. Noticing strong or irregular heartbeat, so palpitations, muscle discomfort, trembling, dry mouth. So sympathetically more aroused, dry mouth, excessive sweating, once again, sympathetically more aroused, shortness of breath, once again, sympathetically more aroused, stomach ache, you could draw it to the same thing, feeling sick, you draw it to the same thing, headache, see in a bit, pins and needles, difficulty falling or staying awake. PTSD, hyperarousal, feeling on edge. We can see here very similar to anxiety. I think as well as that, a common symptom is inability to feel, inability to actually have a healthy relationship with their emotions. Re-experiencing the trauma, flashbacks, nightmares, distressing images, physical sensations, pain, sweating, feeling sick. So we've got some people have a constant negative thought about their experience, repeatedly asking themselves questions that prevent them from coming to terms with the event. For example, they may wonder why the event happened to them and if they could have done anything to stop it, which can lead to feelings of guilt or shame. I think this is the last one coming up. Personality disorders. Once again, personality disorders are heavily correlated to child abuse. If you have BPD, you might experience the following: rage, sorrow, shame, panic, terror, long-term feelings of emptiness or loneliness. One thing to be careful of is that many patients with personality disorders have a fear of abandonment. The issue with this is we don't want the patient to position us as the hero or position us as a solution to their problem. We want that patient, as much as we can, to become the hero of their own story, the hero of their own presentation. If they have attachment issues, this can sometimes be a bit of an issue in empowering them. Disturbs pattern of thinking. So we've got here upsetting thoughts, dread, guilt, brief episodes of strange experiences. So like noisy heads, that's quite a common thing, that where they feel that they've got these negative automated thoughts. Prolonged episodes of abnormal experiences, so hallucinations, night terrors, and real morbid thoughts. All right. So we're now going to move on to how we get in and out of the patient's way. Now, the entire aim here is to. Do you mind if I get the call quickly? I'll be 2 seconds.
Great chat, guys.
Sorry, guys. All right, cool. So, psychology and getting out of our, psychological intervention. Have we gone past this already? 1 second. That's it. Getting in and out of the patient's way. Now, there's multiple ways which we can actually delay the recovery of the patient. Now, to go away from, or when I say away from and towards, away from, I mean away from their recovery, towards, I mean towards their recovery and towards their well-being. Now, away from here, we've got being allopathic, or let's say the allopathic model, reductionist, or practitioner-led. Now, the issue with this, with any form of reductionism, is we lose sight of the patient. As well as that, by leading the patient, we lose sight of the patient again, and we lose rapport with the patient. The reason why this is important is that, for example, I can say from an osteopathic perspective that osteopaths are inherently anatomically reductionist. A doctor, for example, might be once again anatomically or physiologically reductionist. So they are not seeing the patient, they purely see a strain or an injury or pain. It makes it a lot easier for the practitioner, but it makes it a lot harder to actually get good outcomes, and it makes it a lot harder for the patient to succeed. We want to be holistic and patient-led. Now, you would have heard me talk about the hero story. The hero story is was taken up by early psychologists. So specifically Carl Jung and Eric, last name Eric Newman or Erikman. I'll have to, he's written a book called The Origins and History of Consciousness. Now, they use myths to understand human interactions and human psychology. It's very, very important that our patients become the hero of their story and that we are their guide. Many patients will come to us expecting us to be their hero, i.e. we're going to click this, rub this, it's going to be sorted. It's very important that we empower our patients, especially those with mental illness, because to take control, yeah, that's it. A lot of presentations with pain, and especially with mental illness and pain, the patient needs control. Control has a naturally desensitizing effect. If someone understands what's going on, if they have control over what's going on, if they have power of what's going on, their progress will be a lot smoother than if they're waiting for that 30 minutes once a week where they get to see you. Passive patient intervention, once again, disempowers. We want to have a proactive, patient-participated, controlled experience by the patient. Uncertainty and indefinite length of treatment, both of these are also bad. We want to give the patient some form of control and predictability. Now, this would be, for example, us clearly explaining what's going on, using non-anatomical terms, using metaphors that enable them to understand that we're actually just dealing with pain here. We're not dealing with a lump, we're not dealing with inflammation or a tear, we're just dealing with pain. We'll go into metaphors in a second. We want predictable, routine, goal-orientated intervention. We want to go away from anatomical terms. And anatomy has very little correlation to pain. We've seen hundreds of times that through research and the collection of data, that MRI findings have no correlation to patient pain. It's a difference between hardware and software in the body. Pain is software, anatomy is hardware. You can have a software problem without a hardware problem, as we often see. The issue with using anatomical terms or being excessively anatomical is it encourages maladaptive thoughts, which is that something's in there, I have no control over it and I can't see it, but I know something's wrong because my practitioner told me so, or my MRI told me so. We want novel terms which are relatable, such as pain, discomfort, and tension. Longer examination times have been linked, long examination times and long treatment times have been linked to poorer outcomes. So the reason why, I think this research was reviewed by Dr. Sandy Hilton, that essentially found that those practitioners who examined for longer, I think they actually manipulated it. They manipulated the examination and the consultation time. And they found that those who had a longer examination time and a shorter consultation time, i.e. the practitioner was rushing them through the questions and they took a long time examining them, they found those patients actually fared worse off than the patients who had a longer consultation time and a short examination time. The reason why is the patients who have a long consultation time and a shorter examination time, they're going for a naturally cathartic experience. They're expressing their pain. They're telling you exactly what's wrong. They get everything off their chest. They have an understanding that the practitioner has a fairly good idea of what's going on because they were able to get everything off their chest. And then what a shorter examination period does is it actually shows them that nothing's actually much wrong because he only took 5 minutes looking at it. So it must be all right. You can imagine how if you, for example, were with a doctor and that doctor was taking multiple tests and he was huffing and puffing and trying to figure out what's going on, you can probably naturally imagine your anxiety starting to build. Whereas if they kind of just checked it over, said, yeah, it's all good, we can work on this, and this to go forward, it has a desensitizing effect. Assumptions of patients' understanding, this goes away from as well. We want expert to expert consultation. So bear in mind that the patient is an expert in their experience, in their pain presentation. We are experts in helping them, and we want to make sure that we get a good, thorough idea of that patient's understanding and interpretation of what's going on. One thing which can also cause us to go away from a good outcome is excessive amounts of empathy. We want appropriate empathy. The reason why is that a patient may look to us and they're looking for a calm, gathered, definitely non-judgmental, non-catastrophic, controlled demeanor to take them forward. So yes, we can acknowledge their pain and say that must be really difficult for you, but we don't want to be so emotionally involved with their case that that patient is getting signals that something really serious is going on, but also that the practitioner doesn't have their stuff together to help them through it. So we want to be empathetic, but at the same time, we need to be a rock for them. So, yeah, go on, Ellie.
Say, for example, someone was like, oh, I'm really suffering, blah, blah, blah. And then just in conversation after you've done like observation, all of that, you were like, yeah, I can imagine it is really painful, but we can sort it. That's yeah,
of course, that's fine. That's absolutely fine. Yeah, that's not a problem. I'm talking about, say, if as close as possible to practitioner and patient crying together, because it's such an emotionally provocative experience like that. Yeah, that's which we wouldn't, and especially you, Ellie, you wouldn't ever fall into that trap. but it's
what was I going to say? Can I say something? So Ellie, I think what you're doing by saying that to the patient is you're showing that you understand and you're being empathetic, and then you're saying to them that you can help them. So I think by recognizing that you understand, a lot of the time patients feel like go to their GP, they just don't look at them, they look at their screen the whole time, whereas we give them the time and we understand their pains. And so by saying, I understand this, they then buy into you more.
Yeah.
That makes sense.
Yeah, I did think that, but I was just checking.
Yeah. One thing we're going to go into later is labeling. So labeling is a way to build rapport with our patients, and labeling is almost a way of reading that patient's mind. So, for example, the patient comes in, they've got 3 young children, and they've got chronic lower back pain. They're a single mother, and you saying something like, "If I was you, I can imagine feeling very, very frustrated to have that amount of back pain and have to take care of 3 kids at the same time." That is a way, once again, that you can use their experience. You can map together their experience to show empathy and also build rapport at the same time, and show that you thoroughly understand their situation. So in this section, we're going to cover the psychological tools which are available to us. We're going to cover CBT, Socratic questioning, metaphors, and mirroring, motivational interviewing, cues for rehab, the difference between external movement cues and internal movement cues, and cues for exposure to load. We're also going to go through mindfulness, i.e. body scanning meditation. So CBT, Socratic questioning. Socratic questioning was popularized by the philosopher Socrates thousands of years ago. Now, the benefit of Socratic questioning is it allows us to communicate with the patient to help them find rational truth. Once again, this is helping them to use their logic, their prefrontal cortex, to dampen the emotions within the amygdala, which are negatively contributing to their pain. We're going to use this in the context of what we've previously discussed. We can educate patients to reinforce this. Common examples would be, for example, Socratic questioning is using the how, what, whys, wheres, and whens. Common example would be the patient saying, "I'm really concerned that something is seriously wrong." Well, what makes you think that something is seriously wrong? Now, as soon as you're asking this question, you're instilling doubt. Up until that point, that patient was certain, more or less, that something was wrong, at least on an emotional level. Now you're asking them to provide evidence. As soon as you ask someone to provide evidence, you're instilling doubt. "I don't know." So once again, this is the patient responding, "I don't know. It's just so painful." They're starting to show doubt. Then you can educate. Pain normally occurs before damage. It's our body's way of protecting us. You can frame this in a pot. So by saying that pain is trying to protect you, you're reframing pain in a positive light. It's no longer the enemy. It's the friend which has got out of control. The patient might then say, "Okay, I need to pick my child up, but I can't care for him," showing distress. "Is there something that is lighter than your child which you could pick up?" "Yes, I can pick up lighter objects." If we get used to picking up lighter things, by next week, you should be able to pick up heavier things. We can then build this in stages for you to pick up and care for your child. You're offering a solution, you're offering a controlled, predictable solution, and as well as that, the patient can envision their future forward. They can envision their triumph over their discomfort. So, Socratic questioning. By nature, it's concise, directed, and clear. Open, yet with purpose, focused, but tentative and neutral. Most important thing is not to judge. You're not challenging them to make them look like an idiot. You're not challenging them to show the foolishness. You're challenging them to explore. You just want them to explore the rationality of what they're presenting with. Any questions on that at all? Cool. So yeah, no problem. All right. Let's see if we've missed anything out from here. Yeah, so these are common examples of Socratic questioning. What do you mean by that? Is there a different point of view? These are more specific for counseling. They might come up for you. They might be useful for you. Evidence is a big one. So, for example, I'll say to a patient, for example, I'll ask them, could be anything from, okay, for example, they can't stand up and touch their toes, but they can sit down and touch their toes. For me, then asking them, do you see that's quite a similar movement, but one's painful and one's not? Yeah. Okay. We just need to. There's just a bridge that we need to close in the meantime. Then we can work on that. It's something like that. Turning a few points not really relevant for us. Yeah, that's about it. Okay. Metaphors, as we discussed before. So metaphors are a bridge between your mind and the patient's mind. You're using commonly relatable experiences or ideas to get your idea across. We want to replace catastrophic metaphors with more novel, controlled, empowering metaphors to now enable that individual to understand their pain. Every metaphor has an underlying narrative linked to the experience of the patient. Metaphors are very, very common in not just human experience, but also in human language and human words. So even the term understanding, nothing is understanding. It's just that you're saying that you get the idea. You could stand under it and hold it up, for example. So these are catastrophizing metaphors and descriptions that our patients would often use. I have the spine of a 70-year-old. It's trapped. It's a nervy pain. Something slipped. I felt something go pop. None of these empower the patient. Anti-aging is not a possibility. If something's trapped, it's unlikely that the patient knows how to get it out. Something slipped, same again. I felt something go pop. They're using structural ideas. They're asking you to help them a lot of the time to put it back into place, to untrap it, anything like that. It's very important that we do our best not to play into these metaphors. We don't want to say that I've released that nerve or I've popped that back into place. Not that we would, but just in case. Now, novel metaphors. Sorry, I'm just going to get the call again. I'll be 2 seconds. Good afternoon, Vice Clinic. Yeah, when would you like to come in? Yeah, what time would you like? And which day? Yeah. Yeah, so Monday I've got one more appointment at 10:40, if that's good for you. That's it. That's it. Yeah, I'm just going to take your details. What's your full name, please? And your mobile number, please. If not, I'll take your mobile number here. Sorry, I'll take your landline here, and then I can always get it from you when I see you. No problem. That's fine. All right, Sylvia, that's all booked in. How did you hear of us? How did you hear of us? Okay, thank you. That's all booked in. Not a problem. So I'll assess you. That's booked in for your free consultation. and then we'll assess the injury, and I'll tell you from there what you need to do. Yeah, that's fine. If it's not traumatic, that's fine. I can still diagnose it and tell you what we need to do. All right. My name's Elliot. Yep, sweet. Thank you. Take care. See you. We're just opposite Gravesend Library. All right. Thank you. Take care. Bye.
Elliot, just so you know, I'm gonna be going at past because I've got a client. Yeah.
Yeah, that's fine. I'll record it all anyway, so I'll put it up on YouTube.
Yeah. No.
All right. Cool. Any questions so far? All good? All right. So, better metaphors are metaphors which show pain to be actually something which is functional, something which is positive, but something that's got out of control. So, for example, pain is an alarm system. You've tripped the alarm system. We just need to gradually turn the volume down on that alarm system again. We need to build this back up. So that empowers the patient because they can probably understand the idea of building areas or building strength again. Pain is a threshold. So once again, that's linked to the alarm analogy. So something I might say, because patients want a cause, they want to understand what caused their pain. I'll say something on lines as well. Pain is a threshold. That threshold is that threshold interacts with different areas of the brain as well. For example, your emotions. And it's most likely that it was quite a few things that were feeding into that threshold, and then one thing just tips it over the edge. But don't worry, you haven't damaged anything. Pain often occurs before damage, and we just need to refine that threshold, make sure that you're more tolerant before you develop these flare-ups, or make sure that we increase the capacity for you to deal with load, so you don't encounter these flare-ups so often, and then we can go from there. And then once again, looking at pain as a protective response. And to be honest, the metaphors that you can use are endless. I think that most practitioners develop them from their own experience. I think I discussed with Charmaine one earlier, but I can't remember what it was. It was about bones, I think. Can't remember
now.
Yeah. All right, mirroring. So this is something that we can use to build rapport with our patients. Many patients, especially those with mental illness, may be less trusting, more pessimistic of outcomes. They often have had quite a traumatic experience with healthcare workers, especially with more reductionist healthcare practitioners. They may have, so that will lead into their further distrust. They may have elevated emotions surrounding appointments. Mirroring enables us to build rapport, reduce stress, and build confidence. Now, there are multiple ways which we can mirror. We can mirror via our language or our physicality. It is shown via research to improve rapport or closeness. Remember that our experience with the patient is relational. So the relationship between us and the patient will heavily impact the outcome. We want that relationship to be one of trust, one of obviously barriers, but at the same time, one which empowers the patient, where we keep to our role as a guide. Now, you can mirror via body language. That will be the equivalent of if the patient's arms are folded, my arms are folded. If the patient leans forward, I can subtly lean forward. But I would say that this is less essential, and it's more difficult to do without looking like an idiot. We can mirror more effectively via language. Now, I think that the most effective way to do this is simply to repeat what the patient has told me after I've gone through a case history. The reason why is that one of that patient's fears might be that they're not understood. A lot of the time when the patient relays their information, they do it in a very chaotic manner. It's all over the place, but because of our ability to take good case history notes, we can structure it for them. So one thing I might say, for example, is before we go into the examination, I will say, Sarah, I'm just going to repeat this to you. Please tell me if there's anything which I've got wrong. So I'll say, so you have lower back pain, it's focused more on the right than the left, and you feel like you've got this lancinating pain down the back of your leg. This occurred 5 years ago. You're not too sure why, but you said you went through quite a difficult divorce at the time, and you had to move house, and you're quite physically active in doing so. Over the past 5 years, it's fluctuated up and down, but you feel like it's mainly aggravated by sitting for long periods of time, especially if you're in a slumped position, and that you find it very difficult when you're feeling emotionally stressed. You feel like that aggravates your pain as well. But you have said that you feel better, for example, when you're on holiday, or when you are able to rest, but also you have quite a beneficial relationship with exercise. You feel better after exercise. Is that everything? And then if they say, yeah, that's everything, that's good. It means that you've once again, you've solidified that rapport with them. You understand what's going on, and they appreciate that understanding. But you can also just pick up on a few things from each sentence. So for example, it might be that they say, I can't pick anything up. You can't pick up anything. No, I can't pick up my kids. I can't do this. That must be very frustrating. Tell me more about you not being able to care for your kids. And it's a way that you can listen, repeat something back to them. And once again, it builds rapport, but it will also help you to build a better understanding of what's going on. One thing which I find, once again, really effective is labeling, highlighting the patient's emotions, picking up on being able to put yourself in that patient's shoes and thinking about how you would feel. God, that must be really frustrating for you. That must be really painful. Do you often find that you have to sit through the pain for a long period of time? If it's painful after 5 minutes of sitting, but you've got a desk-bound job, you can get a better understanding of the emotional content behind what they're experiencing, but also once again, helps to build rapport. Any questions at all? All good? Motivational interviewing. Motivational interviewing blends a lot with what we've already discussed. I really like this because it uses what the patient is already saying to help them. It's using their distress to help them. So this is very good specifically for us as pain clinicians, especially for those patients who have an inkling of what they should be doing anyway. It is very useful for guiding conversation to encourage outcomes. This is by exploring towards and the away from their goal. For example, I know I need to exercise. Why do you say that? Because my weight can't be helping this. And then you can support that notion. Actually, you're 100% right. We can see that there's really beneficial trends between weight loss and pain reduction, because an increased amount of body fat can increase the amount of inflammation in the body. Have you thought of any ways that you might try to exercise more? And you can go down that link, and you can use them and use their ideas and use their hunches and their existing knowledge base to help to create a program for them which is specific. They've had a chance to build it with you. It improves rapport. It's patient-led. They can become the hero of their story. That's the most important thing. You need to go now, Jess. I'll see you in a bit. All the best. The patient might also say, so this is their away from. This is them highlighting what's negative. I know I shouldn't Google my symptoms so much. Well, why do you say that? Because I'm probably just getting myself worked up. And you support the notion with evidence. Absolutely, 100% right. Having a catastrophic idea of what's going on can actually upregulate your pain. Are there times where you're less likely to think about your condition? So this might be, for example, when they socialize, when they're sitting watching the TV. If they're able to lay in bed and read or something like that, they might notice that their pain drops. You can use that in their self-management and highlight that or prescribe it. So I need you to do more of these things that make you feel good. Once again, the patient's already come up with the idea. It's a lot easier to do. It's less prescriptive. It's patient-led. We'll now go on to cues for rehab. Once again, this is ways. Yeah.
What was I going to say? So I don't know if you're probably finding as well, but a lot of patients use that COVID as an excuse. All the things they like to do, they can't do. So that it's really hard for them to try and find something they like to do that helps with their pain, because everything they like to do, they can't do.
Yeah, and that's obviously why they've come here, right? But it might be that they've come in with their main goal, which is they want to be able to go back to the gym again, but they might find that things that are still keeping them moving, but and they have a semi kind of enjoyable relationship with, either reduces their pain or doesn't increase it. So it might be, for example, someone can't run, but they can walk. And by prescribing that and asking them to give up or to give forth certain ways which they can still move, but they actually feel good whilst doing it. Even if you needed one more step in and say, well, what do you think about spending less time running just for the moment and spending more time walking? Would that be a good idea? Would you be able to do that? That's a way that you can, I suppose, 100%, you're not getting them back into what they're doing straight away, but you're using a patient-led communication to come up with ideas which are still desensitizing for them, still increase their activity. They're still going to get a bit of an endorphin rush from. So yeah, is that all right?
Yeah, I was going to say, so generally you always get patients like that always focus on the negatives, and it's trying to get them to think about actually what can you do other than what can't you do.
Yeah, and I think motivational interviewing is a great way to do that. So the rehab should aim to empower, to build confidence, drawing attention to function, task at hand. We can communicate this in ways to specifically do this. External movement cues are our friend. Internal movement cues I avoid as much as I can, unless I want to try and build a novel relationship with, say, a muscular contraction. So say, for example, if someone is, I don't know, say if someone is scared of a certain sensation, to give them that sensation in another way, that I might use internal movement cues then. But most of the time, I'm going to be using external movement cues. Internal movement cues draw the attention towards their body. Now, if that individual's in pain, their attention is already on their body. When we walk, we don't think about what our knees and our hips are doing. We don't need any internal movement cues. We focus on external movement cues anyway. That patient is already internalizing their movement. We want to externalize it as much as possible. An internal movement cue might be squeeze the glutes. External movement cue, which does the same thing, for example, while squatting, is rev the floor. Tense your shoulders. That's an internal movement cue. Rev the bar is an external movement cue. Straighten your knees and push the hips forward, or you could say push your head through the ceiling when you're squatting. Yeah, is that clear for everyone, or have you got any questions about that? All good? Sweet. All right. Other refinements to consider. So closed kinetic chains, i.e. when the applicator is fixed. So the closed kinetic chain would be a push-up. Open kinetic chain would be a bench press. Closed kinetic chain would be say something that looks like a handstand, and an open kinetic chain would be an overhead press. Whenever the applicator is fixed, it's a closed kinetic chain. This has shown to have desensitizing qualities to it. It reduces pain. And it also enables that individual to put a lot more force into the movement without getting a painful response. For patients with mental illness, it will also give them more information. They can gain more information from the ground, therefore they'll feel more secure. When it comes to general activity, we find that those individuals who participate in volume-based exercise, so like long distance running, for example, they have higher pain endurance. They can deal with pain for longer. Those who do more intense exercise, 100-meter sprint, weight training, they can deal with higher levels of pain. We can use these appropriately if we wanted to for patient-specific experiences. For example, if someone can't deal with this gnawing underlying pain for a long period of time, we can give them exercises to improve their durability. Research has also shown, and once again, I can't find the study, for example, I'm afraid, but I did read it. Multidisciplinary approaches have shown to be more effective. So do not be afraid to suggest that another practitioner gets involved. I have countless patients who I've treated and they have not made significant improvements until they've got CBT or a psychologist. They carried on seeing me, but it's just enabled me to focus on the physical, and the psychologist can focus on the psychological intervention. Same thing, I've often treated patients with Yulia as well. So I'll treat the pain and the physicality of it, and Yulia will treat the physiological side of it with a herbal medicine. We want to keep the exercises rewarding to improve the likelihood of completion and build positive relationships with exercise. Do not be afraid to make the exercises tough. A common rule of thumb that I give is a 3-4 out of 10 level of pain, or if pain reduces after 2-3 hours of completion, that's fine, but keep to that whilst trying to reach about a 7 out of 10 level of intensity or difficulty with the exercises. General rule of thumb is that a 6 out of 10 level of intensity on the RPE level maintains. Anything above that starts to improve hypertrophy or strength or endurance, whatever you want. Anything above an 8 out of 10 increases likelihood of injury. So 8 is really the sweet spot. You want to monitor their confidence levels. So a common question I'll ask is a patient, I'll ask 3 questions. First of all, on a scale of 0 to 10, where do you feel yourself now? 0 being where we started and 10 being where you want to be. I have patients who tell me 40% they're 40% progressed, but their pain, when I ask them out of 10, is like a 1 or a 2. One of the only things left after that is their confidence. Well, how confident are you out of 10 that this is going to be it? You know, your pain is a 1 out of 10. How confident are you that it's going to stay that way and that you're able to do everything that you want to do after that? They might then say that they're only like 60% confident. So then we need to provide more evidence for them that everything's fine. So we scale up. That might be, for example, a typical example, if we bring it back to just, you know, standard sports would be football, that they can do everything in the gym, they can do on their long distance runs, but they're really lacking confidence that they'll be able to last the game. We need to bring something, a bridge, which closes that gap between the game and the gym or the treatment room. Appropriate frequency of appointments by spreading appointments out more. If their confidence is high. So when their pain's low, when their confidence is creeping up, that's a point where I'll start to really spread their appointments out. Confidence or a lack of confidence or pessimism in movement has a positive correlation to pain. Those patients who are least confident, more and more pessimistic, they think that an injury is more likely to occur. Those patients are more likely to injure themselves. We can see this with footballers when those individuals are looking. In a study looked at footballers and their readiness for play. Those individuals who had a lower confidence were more likely to suffer from an injury. Does the pain serve the patient? i.e., are they using their pain as leverage? Does their pain get them out of doing things they don't want to do? For example, work. Do certain tasks around the house. If that's the case, I often have very honest conversations with my patients. Is this pain serving you at all? I know that you said that you feel like you can't work. How do you feel about work at the moment? Do you enjoy it? Is it something that you're dreading? I had a patient who said to me that she wanted me to write a letter for her supervisor at work, or for the occupational therapist at work, or something like that, on-site doctor at work. And I was like, well, why do you want me to write the letter? She said, because it's too painful to work. And I said, well, just out of interest, you can be completely honest with me here. I said, even if it was possible for me to get you pain-free, would you want to go back to work? No, definitely not. At that point, there's no chance for me to rehabilitate her. There's no chance for me to treat her. The best case scenario is I can either play into her story or her hero story, which is that she triumphs by medically retiring, or I have to negotiate with her and find something which is a little bit more realistic. But that's what being patient-led is all about, as far as I'm aware, as far as I'm concerned. When it comes to the red flags, this is where I can't remember the guidelines, to be honest, for me as an osteopath. I know that other practitioners go down the lines, and you might be able to educate me on this, that when the patient is of significant harm to themselves, that you can refer. But the red flags would be isolation from loved ones, increased job, school apathy, memory, attention, concentration, reducing, fluctuating sleep, mood, behavior, hopelessness, crying, sadness, etc. And it goes on. Obviously, if that patient is contemplating taking their life, that's obviously another red flag. I don't know if you guys know about your guidelines for this. No? I'll have to look it up.
No.
I haven't ever encountered a psychological or mental illness red flag, but yeah, I'll have to look it up. All right. Have you got any questions, guys? Or any feedback? Anything you wanted to discuss?
No, it's really good, Elliot. Thank you.
No problem. All good. All right, sweet. I'll let me just pause this anyway. Cool. So I'll upload this so you can tap into it at any point in time. So let's set up. If we set up our next CPD for like 6 weeks time, is that all right? All right, sweet. Cool. That format, was that format all right for everyone? Did you feel that you wanted anything more, or?
No, I thought it was really good. It is really helpful.
Yeah.
And I
Okay.
think that it's, so basically, like, obviously, general rule of thumb, a lot of this applies to all patients, but some of it just applies to chronic pain, right?
More for chronic pain, mental illness. I would say that whenever their pain is more biased towards the psychological of the biopsychosocial model,
Yeah.
that is when these toolkits for me start to, or this what we've covered starts to become more important. So it's a toolkit that we can use for every patient, but I find myself biasing more towards this side of things when that patient's presentation is more psychological.
Yeah.
When it comes to mental illnesses, obviously we're not going to treat mental illness. We're going to treat a possible component of their mental illness if their pain is contributing to their mental illness. But other than that, it might be having to navigate their pain picture, navigate their story, putting it into the context of their mental illness.
Yeah.
Also, I think for me, it enables me to get less frustrated at times because, for example, I've got a patient at the moment, once again, me and David are both treated, and it's a brilliant example, right? So she came in and she said this is the best that she's felt in 4 months or 5 months. It's the best that she's felt. Both me and David had very fluctuating success with her, so she'd get better and then she'd go down, better and then she'd go down. She said to me that what you did last time really helped. I had such good pain relief after that. All she was talking about was foraminal gapping, so me just side bending her spine. In my head, I was like, "That's BS. There's no way that was what caused you relief." I said, "Well, tell me what else you've been up to then. What else happened?" She said, "I told my boss to fuck off the other day." I said, "Really?" She said, "Yeah. He was working me like a dog. He was making me work through my pain. I told him, fuck off. I'm not doing that anymore." And I said, "Okay." I said, and that worked, I take it. She said, yeah. I'm only working 3 days a week now. I said, "Do you think that might be contributing to your pain relief at all?" She went, 100%. Yeah. So, and I've had loads of patients who haven't actually had tangible success until they'd seen a therapist, a counselor, or a psychotherapist. So.
Yeah, I just think as well, sometimes it almost like gets you down a little bit because like it's like, what am I doing wrong? I'm not having any success, and I think that's that's a big thing that kind of I felt like, you know, with the patients we were talking about earlier, and that one actually, it's kind of like, you know, because that fluctuation is constantly there.
Absolutely, 100%. But I think that, you know, I was talking to Charmaine about this yesterday, I think, or might have been last week, and it's that the patient's brain, the patient's mind is just a never-ending ocean, and we're a drop in it. Like if and the other thing is, when it comes to that ocean, they are literally just a cruise ship sitting on top of it. They don't know what's going on. I had a patient who came in earlier today, and I've been trying to tell her over and over again. I've been trying to get into this conversation over and over again, asking her why her pain at work is so bad, but she comes home and does the exact same thing and the pain's not there. Do you think that, how do you feel about work? Do you think there might be some kind of psychological influence there? And finally today, it's the last week, and she said, "I'm hearing you loud and clear. I think my pain is 100% mainly psychological." And it gave her relief because she knows there's nothing wrong. There's no point chasing anything. Her work's coming to an end, so that gives her relief. But for me, it gives me a perspective which I can deal with. You know, like I can deal with the perspective that I'm merely an observer and a guide. And if I can't get that patient to go where I want them to go, or where I think they need to go, then that sometimes we can't have an influence on some things. Just letting it go, I think, is learning more about the psychology helps me more to do that.
It's definitely helped me, like, because I had a client last week and she was literally had every surgery under the sun. And you know, when you think, like, I know there's nothing actually wrong with you because everything showed that there's not.
Yeah.
And it's like, and I was a bit thinking, like, how am I going to deal with this? Like, how do you deal with this? But that's definitely helped. I'm seeing her next week. So
Awesome. I personally think that those patients who have dipped their toe into the world of surgery for their pain are far more difficult to treat because they have given up all power over their condition. They've given up consciousness. They've given, in terms of when they have to go under, they've given up their any influence over it at all. They're allowing someone to cut them open to take their pain away. Those individuals I find are the hardest to swing round to what is more of an evidence-based approach to their pain, which is to empower them more. And I mean, I don't know if you guys have experienced it where you have patients who literally love their surgeon. I saw Mr. Simpson, fantastic, highly qualified, cut my shoulder open, sorted it right out. Didn't need it. Yeah, it didn't need the surgery. You didn't need the surgery on your knee, any of this. But they've committed, and they've deified their surgeon. Not good, but they've done it.
And you have to go, oh, that's really good.
Yeah, exactly that. 100%. Yeah. All right. Any questions at all?
No, that was really good. Thanks, Elliot.
All right, no problem at all. I'll message Justin to tell him that he's up.
Okay. Cool.
Okay.
Sweet. All right. I'll see you in a bit. Take care.
All right. See ya.